All right, well, we'll go ahead and get started just so that we have as much time as possible. We want these to be, a little more chance for people to interact. So we have a fabulous lineup of talks. We have 7 speakers who are going to be sharing their great work today. And the plan is that each person will talk for a maximum of 5 minutes for their flash talk, and then we'll have time for a couple of minutes for questions. And if people go over, then we'll reduce the time for questions. But we're looking forward to diving in. So before we get started, let me just check. Does anybody have any questions about the format? Wonderful. All right, well then let's start with our first talk is Advancing the Science of Digital Mental Health, NIH Areas of Focus and Future Directions. And I think we have Beth will share screen for that.
Yes, absolutely. Can everyone see my screen? Sorry, is everyone able to hear?
You're good.
Let's see. Okay, thank you. All right. Hi, everyone. I'm thrilled to be a part of this excellent event today. Before I get started, I want to mention that the information in this presentation represents the views of the authors listed here and doesn't necessarily represent the views of NIH or the Department of Health and Human Services. My name is Beth Jaworski, and I'm at the Office of Behavioral and Social Sciences Research at NIH. And today I'll be sharing a bit about NIH areas of focus and future directions for advancing the science of digital mental health. As you might imagine, in the span of 5 minutes, I can't provide a comprehensive review of all the activities, but hope to showcase some of what is currently being done and what is on the horizon. Digital health is an important focus at NIH and is receiving increasing attention. There are currently nearly 2,000 active funded digital health projects. The National Cancer Institute has the most number of active projects, closely followed by NIMH and the National Institute on Aging, National Heart, Lung, and Blood Institute, and the National Institute on Drug Abuse round out the top 5 institutes and centers supporting the greatest number of digital health research projects. Although the codes that are used to categorize the projects are not perfect, you can hopefully get a sense that mental health related research is an important area of focus among the currently funded digital health projects. There are many active funding opportunity announcements. Here are just a few examples that showcase some places where digital mental health is being addressed, including a focus on using health information technologies to alleviate health disparities, healthcare models for persons with multiple chronic conditions to advance health equity, laboratories to optimize digital health, and developing digital therapeutics for substance use disorders. As has been discussed in a number of the other sessions and poster presentations yesterday, digital mental health researchers in the digital mental health field face a number of challenges, including the speed of technology development, communication across the many disciplines that comprise digital mental health, crafting truly informed consent, the integration of user-centered design into digital health products and services, and the need for dissemination, implementation, and sustainability plans. I'd like to highlight just a few ways in which NIH is working to address some of the challenges in digital mental health research. They include the Small Business Innovation Research and Small Business Technology Transfer programs. These programs are competitive and encourage small US owned and operated businesses to engage in federal R&D with the potential for commercialization. The NIH Small Business Education and Entrepreneurial Development Program, or SEED, is an excellent resource. If you have any questions about SBIR, STTR, or if you're not even quite sure where to start or what you might need, they work across NIH with both small business innovators and folks in academia to help support innovations in health and healthcare. The All of Us Research Program is another example of NIH-wide collaboration and innovation. The All of Us program has the goal of enrolling 1 million participants. A wide array of data are being collected, including genomic data, mental health related data, and will also include some social determinants of health, among others. The program has and is continuing to refine custom software and tools, including a mobile app for participant data collection and a researcher workbench to explore the data that have been collected so far. And lastly, I'd like to share the Team Science Toolkit created by the National Cancer Institute. Digital mental health research brings together people from many different disciplines, and this is a great strength of the field, but can also pose some challenges. And the Team Science Toolkit is one resource that can be helpful when working across a team that might, for example, include psychologists, psychiatrists, social workers, community members, designers, engineers, and data scientists. In order to continue advancing the science of digital mental health, Some of NIH's primary efforts include research opportunities in the form of grant making. I don't think that is surprising to anyone here. However, I think it's worth mentioning that health equity is a priority at NIH, and digital mental health can be integrated into a wide range of funding opportunities, even if the funding announcement does not specifically mention digital health. And also, if there's a funding announcement that you have any questions about, you could always and should always contact the program officer that's listed on the funding announcement. Program officers are there to help and answer any questions that researchers might have. NIH also supports a number of training initiatives like the mHealth Training Institute. The call for applications typically goes out in about December, and the week-long training institute is held in July at UCLA. And lastly, NIH often holds events such as webinars and workshops that are free and open to the public and have been and will likely continue to be virtual, or at least have virtual options. One event that I'd like to highlight is that I think might be of interest to attendees here today is the workshop that will be about 1 month from now. It's the Digital Health Interventions from Wellness to Therapeutics, Development and Dissemination. This workshop is virtual and registration is available at dhiworkshop.com. The event will be 2 half days on July 12th and July 13th, and will include speakers from academia and industry, with sessions focused on characterizing the continuum of digital health interventions, designing interventions for equity, privacy, and impact. And the final session will be focused on opportunities for commercialization, dissemination, and reimbursement. Please feel free to reach out about any of the information I've presented today, or if you have any questions. And thanks so much for your time.
Wonderful. Thank you so much. Let me open it up for questions. Ton of great info there. I'm happy to start us off. I wonder if you could comment on, if you were to be giving this talk again in 5 years, how do you think it would look different in terms of the trends and focus relative to where it's at now?
That is a great question. I would love to see more work that is focused on integration across systems, that shows, I think, more maturity. I know that there have been amazing leaps and bounds since the pandemic has started, but I think there have been a lot of, as people have mentioned in other sessions, a lot of one-off projects, and I'd love to see a more integrated approach, and an approach that really addresses the needs, I think, of the folks who are purported to be most helped by digital health services. And I think low-income folks, communities that have historically been underserved, digital health and was supposed to be a panacea. And I think, as others have mentioned, that has not been the case. And we tend to be reaching folks that are have more privilege. And so I would love to see more work that integrates user-centered design, integrates all the folks that might be touching a particular product or service and getting their feedback and integrating that into the design intervention process.
Yeah, that's great. Thank you. Absolutely. Any other questions?
I had a quick question. Can somebody put the Zoom link in the chat? I'm unable to join on my iPad.
Well, you must be in if you're here. So how do you mean?
I don't have my iPad connected, and I just need the Zoom link to this meeting so I can join it on my iPad so I can whiteboard.
Are you able? Okay. Let me see what I can do for you. The easiest thing would be actually to phone or email Emma Wolf, because she's available to help with all technical issues. And what we'll do is we'll just switch the order of presentations and you can come back in when you're ready.
Sure, that sounds great. Thank you so much.
No problem. All right. Great. Well, thank you so much, Beth, for sharing that. And you people asked about sort of ability to access some of the resource links and stuff that you mentioned there. And so we'll be sharing the recordings afterwards, but of course, feel free, Beth, to use the chat if you want to put any of the links in there for people to access now. All right. Thank you so much. So I think what we'll do is give Jaan a chance to see if he can problem solve a little bit for moving to his iPad. And what we'll do instead is move on to our third talk next, and that is using digital mental health innovations to address the needs of diverse underserved populations, perspectives from the APA Summit on the future Future of Education and Practice of Psychology. And Paige, let me just check with you. Are you okay with going out of order like that? Oh, you're muted.
I am.
All right, thank you so much. I really appreciate it.
Good day, everyone. I'm sharing my screen. Could someone speak up if they can't hear me or see my slides?
You're good, Paige.
Great. Yes, so today is using digital mental health innovations to address the needs of diverse underserved populations, perspectives from the APA Summit on the Future of Education and Practice of Psychology. This presentation is myself, Dr. Jessica Jackson, who wasn't actually listed on as a presenter, but that must have been an error, and Vaile Wright from the American Psychological Association. Okay, here land acknowledgements, and none of us reported conflicts of interest. Okay, so the American Psychological Association Summit on the Future of Education and Practice of Psychology. For some people who may not be aware, APA is a leading scientific and professional organization representing psychology in the United States with over 130,000 members who are clinicians and researchers and students. Their mission is to promote the advancement, communication, and application of psychological science and knowledge to benefit society and improve lives. A mission I think we could all get behind. So every 10 years, the organization convenes a summit that takes a very big picture look, a 30,000-foot view and perspective for visioning the role of the organization for the next 10 years. The last summit occurred, I think, in 2009. And from that summit came the evidence-based practice model as it applies to psychology. So, you know, weighty, impactful stuff. So for the 2021 summit, the organizers identified two cross-cutting themes, which were science and diversity, equity, and inclusion. For people who may be unaware of that, sort of the nuances about diversity, equity, and inclusion, diversity is about having a variety of voices. Inclusion is about making sure that those voices and perspectives have opportunity to share their expertise, and that these are sort of necessary conditions for equity and justice. So the work of the summit was based on a series of pillars of independent practice, education, workforce development, and licensure and regulations, and for the first time in its history, technology. I was very honored to ask to chair the technology pillar, and many of you in the room were a part of that. I want to describe just a little bit about our process for pre-summit and post-summit as it relates to the talk, because I think the processes are also important to know about how you got to that outcomes. So what you see here is a directory of those who agreed to be part of the technology pillar. There was a pretty intentional process to get representation across types of technology, of which we know there are many, career stage in psychology, and dimensions of personal diversity, gender, sexual orientation, race. And the steering committee worked very hard at that, did ask participants or potential participants to fill out a survey and use that to identify potential gaps. And for the technology pillar, it meant that we asked more people who had expertise or personal experience of disability. We were also so well supported by APA staff and executive committee members. All right, so the first, after establishing the pillar, pre-work included what's called a SWOT analysis. which stands for strengths, weaknesses, opportunities, and threats. It's a tool for strategic planning that takes internal strengths and weaknesses and external opportunities and threat factors into consideration, and trying to contextualize these variables in the development of projects. It helps identify the ways that strengths can be leveraged into opportunities and weaknesses can be overcome to minimize threats. So the process of this SWOT analysis was to send out an anonymous survey to our pillar participants and asking them to give feedback on strengths, weaknesses, opportunities, and threats. I collected those responses and then sent all the responses back out to all the participants, again, anonymized, so that people could maybe modify their own responses if they wanted to, or respond to others. And so what I'm going to share with you next is some of the results of that survey, but I'm really focusing on results that are related to the topic of today's talk in terms of serving minoritized communities. And so there are a lot of strengths that our participants identified as it relates to science-based clinical care. I believe technology can be instrumental for providing efficient access to evidence-based practice, for mitigating barriers to help seeking as it relates to attitudes and, like stigma, and also to mitigate practical barriers. Another interesting thing was that technology can be used to mitigate barriers for trainees. So in clinical psychology, we are striving very hard to increase the diversity of our student body and therefore our work force. And that technology has the opportunity for us to broaden our reach and our impact at an international level. And that gives us the opportunity to communicate directly with the public. So a few of the weaknesses had to do with, as it relates to serving minoritized communities, is accountability and sustainability. I'm going to read these quotes. I think they will say it better than I do. Holding people accountable and making sure that studies geared towards underserved groups are at the forefront, not just for the time being or during the pandemic, but for years to come. The problems have always been there and will continue to be there. And also to focus more on personalized real life issues. So more attention to leveraging the unique features of innovative hardware and software to make mental health treatment more efficient and integrated into the client's daily lives, not just the status quo delivered through a screen. Status quo is definitely sort of a theme about in this summit.
And Paige, I'm so sorry to interrupt, just giving you a heads up, we're at 8 minutes, so we should move towards finishing up when you're ready.
Yep, almost done. And finally, that technology cannot replace a workaround for cultural competences around these issues. There were a lot of things said, but no themes about opportunities. Threats was that the overwhelming evidence base for technology enhanced treatments are conducted on white majority populations, and a one-size-all approach to mental health technology will perpetuate instead of ameliorate existing inequalities. All right. So at the summit, we used results from this analysis to talk within our group. And then we talked outside of our group with the other pillars, and then came back to develop some key points and takeaways, which you can see here. Not replicating this status quo, using technology to help reimagine APA and maybe services in general to be more equitable. The importance of starting with minoritized communities and maybe what is already working with them, and using a ground up approach like community-based participatory action research. Other takeaways is if we do not lead in this space, we will follow. That technology gives us the chance to get like diversity, equity, inclusion right more from the get-go. That our funding decisions need to be driven by our ability to scale, generalize, and repurpose, and the importance of advocacy for healthcare as a human right and technology as a part of that. So that's my thank you.
Thank you so much, Paige. Appreciate it. Wonderful. Unfortunately, we won't have time for questions, so I'm going to move us on, but please reach out to Paige directly. Loads of fabulous information covered there. Next, we're going to hear about systems and policy level considerations to accelerate the implementation of digital behavioral health interventions for prevention and treatment. And do we have Catherine able to share screen? Wonderful. Thank you.
Yes. Can you see, let's see, what do you see? Do you see the notes page or do you see the...
You see the notes page. It's not a problem, but yeah.
Do you see the notes page now?
Now it's presenter mode, so we just see it on the right in your next slide.
Okay. How about that?
There you go.
Okay. Okay. So the title is a little different from what we proposed because we made a last minute pivot because all of the content that had been covered in the conference was basically what we had originally planned to talk about. So we plan to zoom in on one aspect of our abstract, which is about implementation and health equity. And I'm so grateful to have been lined up again right behind the first presenter because she really teed it up well for us. So this is our great team. We have no conflicts of interest to disclose. Just to give you a snapshot of what we all do pretty different things, but all work on development, adaptation, and implementation of digital behavioral health interventions. And we're really united by this passion about accelerating implementation of digital behavioral health that promotes health equity, because existing digital health interventions are either failing those who need it the most or just don't exist. So this is a bit of a different like presentation than a research project. I'll be sharing about a working group that we formed, what we're doing, what we're hoping for, and hopefully you all are interested in the same things and are interested in kind of connecting with us. So despite being in similar departments and doing kind of similar things in digital health, a lot of us on that first screen didn't really work together or talk with each other, kind of similar to what folks have said here. We just kept bumping into each other virtually at faculty meetings, at conferences, and we realized we were having these parallel conversations and struggles with our digital behavioral health research and implementation efforts. And we were like, why has it took so long for us to find out that we were all kind of struggling with the same things? Why aren't we doing this together? Why aren't we talking with each other? And in one of our departments, a grant opportunity came up that could fund our partnership, not necessarily research, but our partnership in the form of a working group aimed at kind of figuring out what are our next steps? How can we all do better in equitable design and implementation of our digital health programs, regardless of the health outcomes we're interested in, regardless of whether we're focused on prevention or treatment, and regardless of the population that we're focused on. So to give you a sense of what this working group partnership development grant can look like, for the last couple of months, we've just been working on getting to know each other, what everybody does, understanding what our mutual networks are, who we're connected to, and what the gaps are, and how the issues that we face in our fields are similar and different. We're also doing a review of health equity and implementation science frameworks and kind of looking at how applicable they are to digital behavioral health and what the gaps are. And in August, we're planning a stakeholder meeting representing community, industry, and various other sectors to really set an agenda for what does health equity in digital health and implementation look like. And some of the things that we wanted to share with you all in terms of design and implementation considerations are if your health outcomes are stigmatized, so a lot of us work in mental health, I and my colleague Dennis work in sexual health and HIV prevention, or do they disproportionately affect a minoritized or the so-called hard to reach populations like adolescents, folks in rural communities, BIPOC folks, et cetera. You should design for equity, or you should think about equity from the get-go. I think that you should design for equity all the time, but particularly with attention to these particular issues. And consider to what extent end users and community members are at the table throughout design and implementation from the very beginning. As folks have noted before, interventions are often designed for main use cases and sort of don't attend to these edge cases or folks who are minoritized or marginalized, but we're arguing, it's really important to attend to those folks first. And if you design for inclusion, then everything else will follow. And in our work, we find that a lot of folks have constraints and limitations to engagement. I work primarily with adolescents who need to participate without their parents' permission. Otherwise, they might get kicked out of their houses and things like that. How might we design for that? How might we design for folks who only have shared spaces to access interventions, inconsistent internet, might share devices with family members, et cetera? And we have a number of ideas, big ideas that we could not fit into this short period of time, but we can't do what we've always done, and we need to do it together. And we have a few ideas that things that researchers can do differently, that funders can do differently. We would love to collaborate with other folks in this space. And I think that I'll close right now since I think I'm out of time, but as we all know, digital interventions can overcome structural barriers, but we also know that they can create barriers if they're not designed and implemented equitably. I cited a few papers that we really like that are kind of inspiring the work that we're doing here. And if you're thinking ambitious thoughts in this space and you're interested in health equity and implementation, please connect with us. These are our Twitter handles, and thank you for our time.
Wonderful. Thank you so much. Let me open it up for questions. I'm happy to start us off. I wonder if you could give a sort of specific example of, one thing that you were thinking about when you said some things that funders could do differently, and one thing that you were thinking about when you said things that researchers could do differently, just to help bring that to life.
Yeah, so I think one thing that we've talked about that we think that funders could do differently is that we know that we've developed a lot of interventions that have shown great efficacy and effectiveness on our various health outcomes. And I think that where we struggle is that's it. We know that they work, but trying to figure out how to get digital behavioral health interventions out there is like just this sort of insurmountable thing that we've all struggled with for the last few years. So if there's some way to sort of bridge, if you have an intervention that is like a evidence-based intervention that's shown efficacy or effectiveness, how can we prioritize funding for implementation research on those interventions, or implement actual real-world implementations of interventions that work? I think for researchers, one thing that I recently learned about that I really fell in love with was this idea of doing rapid, responsive, relevant implementation research, which is the concept that involving everybody that you want to affect at the very end from the very beginning is the ideal way to do things, involving end users, stakeholders, implementers, et cetera, from the beginning. And if they tell you it's not going to work for them, you go back to the drawing board and do something kind of like iteratively so that whatever you come up with at the end is an implementable product. So maybe being a little bit more flexible, and maybe this is speaking to funders as well, being a little bit more flexible in like the design of the actual intervention and not requiring an intervention to be totally like, we've already done this, we know it works, but kind of allowing for more flexibility in what it might look like in the end, so that it meets the needs of the people that we really want to reach.
Fantastic. Thank you so much. We're going to move forward then and hear about using machine learning to identify prognostic predictors of outcomes in a coached web-based intervention, WebStare, for diverse trauma-exposed veterans. And do we have, Haim, am I pronouncing your name correctly?
Yes, you got it. Can you see my slides okay?
Absolutely. Thank you so much.
Perfect. Let me just adjust my window here real quick.
Sure.
All right, yeah, I'm Haim Hollenbeck. I'm a postdoc at National Center for PTSD at Palo Alto VA and at Stanford School of Medicine, and really appreciate all of the talks so far that have really been higher level and so many great resources and guidance to think about offered. I'm going to focus on a really specific project and shift gears a bit and talk about how we're using machine learning to better understand outcomes in the WebStare program. Nothing to disclose. So digital mental health interventions can greatly expand access to mental health care, but not everyone benefits equally from them. Some people may receive higher intensity interventions than what they actually need, while others may not be getting the level of care they need in order to get better. Precision medicine approaches can help to tell us who may not do as well in these interventions so that we can better allocate resources and give more support to those who need them. This endeavor is particularly important for populations who have been chronically underserved. A prognostic index is reflecting of a data-driven approach that combines information from people's baseline characteristics in order to predict a treatment outcome. And so, for example, it can be used to guide the selection of treatments of different intensities. In a recent study in the context of depression, patients with a poor prognosis based on their prognostic index benefited more from a higher intensity treatment, whereas the different intensity treatments did not make a difference if the prognosis was good. So we are in this project working on the initial stages for developing a prognostic index for the WebStare program, which is a it's a web-based version of STARE, which stands for Skills Training in Affective and Interpersonal Regulation. STARE is an evidence-based treatment for trauma survivors and can be a helpful precursor to trauma-focused treatment or as a standalone intervention. WebStare, in particular, was developed to increase access to care for women veterans living in rural areas who reported high rates of military sexual trauma and concerns with social support and relationships. And since its development, WebStare has been expanded to and provided to a broader veteran population over telehealth. WebStare has 10 modules, where the first half is really focused on learning skills for managing emotions, such as emotion surfing seen here. And the second half of the modules focuses on managing relationships. So these modules involve the multimedia delivery of psychoeducation on these topics, as well as interactive exercises to help veterans learn and practice skills. In a recent non-inferiority trial, outcomes related to PTSD, depression, and psychosocial functioning were similarly good between two levels of coaching support as participants went through WebStare. So that coaching support was either in the form of 5 or 10 asynchronous sessions with the coach. Although these coaching conditions are similar at the group level for these outcomes, our eventual goal is to test whether a higher level of coaching in WebStare would be specifically helpful for those with poor prognoses based on their prognostic index. So in this non-inferiority trial, there was a diverse sample of 202 veterans who were mostly women, were relatively racially and ethnically diverse, mostly living in a rural area with a mean age of 44. To select baseline predictors for the prognostic index, a regression-based machine learning algorithm called ElasticNet regularization was used. So this algorithm is pretty good at handling a large number of potentially correlated predictors and has been used for this purpose in past research. So we ran the ElasticNet model 5 times and report only the predictors selected across all 5 models in order to increase the reliability of these findings. We estimated performance by randomly splitting the data into 90% training samples and 10% test samples. The outcome of interest here that we wanted to predict was PTSD symptoms at post-treatment, so at completion of WebStare, which was assessed by the PCL5 self-report. All right, so first, when we averaged across the 5 models, they seem to have at least adequate accuracy in predicting PTSD symptoms at post-treatment. For example, with the R-square suggesting that we were explaining about 65% of the variability in the outcome. We evaluated these 18 baseline characteristics that had sufficient variability in our sample. And as you can see, these characteristics are related to demographics, trauma history, as well as self-report questionnaires completed on symptoms and functioning. Among these characteristics, these 7 were consistently selected, and they were associated with higher PTSD symptom severity at post-treatment, or in other words, worser prognosis in Webster. More specifically, these were younger age, living in an urban area, having a history of being deployed to a combat zone, having higher PTSD and depression symptoms, as well as greater interpersonal problems and functional impairment at baseline. So we'll have more to share soon. These findings are pretty preliminary, and we're working on verifying that these should be the final baseline predictors included in our prognostic index for Webster. And then we'll be working on splitting the sample by poor versus good prognosis to ultimately look at our question of whether more coaching would be helpful for those in the poor prognosis group. Just want to acknowledge my team here for their support in me learning and applying machine learning analyses to this rich Webster data set. And I wanted to acknowledge my postdoc fellowship program as well, and happy to take any questions if there are any.
Wonderful. Thank you so much. We're at 7 minutes, but we might be able to sneak in a quick question if someone has one.
Okay.
Matt, did you have a question?
No, thank you. Thank you. I didn't thank you.
No problem. Well, I'm going to see if we can squeeze one in quickly. I'm super interesting. We've been using some related algorithms to try to predict dropout and stuff like that in some of our trials. And I'm curious whether you think the same predictors that are predicting poor prognosis for symptom reduction would also be what predicts dropout, and if you've looked at that, or whether you would think it would be related or not. Because of course we have the engagement issues as well as the symptom reduction.
Right.
We need to improve on.
Yeah, I think that's a great question. And you're right that these analyses are really on predicting outcomes and whether people get better if they engage, right, as the baseline.
Right.
And
big if.
yes, which is a big if, you're right. And this is a newer area of literature for me, and I'm not sure if what the studies suggest in terms of ones that have looked at both dropout and symptom improvement, whether the predictors are similar across. I imagine there must be some overlap. For example, baseline symptom severity is often one of the, predictors explaining more variance that I could imagine could, apply to both. But this is something that our team is definitely interested in looking at in terms of what predicts attrition in addition to symptom improvement and functional improvement.
Wonderful. Well, we'll look forward to hearing the results as they come in. It's super interesting. I'm going to move us forward now to talk about towards understanding and reducing workplace stress of information workers. Do we have, great. And Merab, am I pronouncing your name correctly?
Yes, you did.
Wonderful. Thank you.
All right. Thank you so much for having us today. So hi, everyone. Today we'll be presenting our research on developing stress sensing systems for information workers and how we can use such system to deliver interventions to reduce the stress levels. My name is Merab bin Morshad, and I'll be presenting our work with my colleague, Esther Howe. Stress is costly, and according to APA, over $300 billion in a year in the US alone is caused by loss of productivity due to stress. In addition, stress is prevalent among the American population, and over 70% Americans report stress from work. With these motivations, we conducted 2 user studies. The first study was to investigate how we can passively detect the stress of information workers. And the second study was on delivering interventions to reduce the stress of the same population. To develop stress sensing system using passively sensed data, we designed a month-long observational study with 50 information workers. We got an IRB approval before conducting the study. After participants were enrolled, we gathered a variety of information at the beginning of the workday, during the workday, and at the end of the workday for our participants. During our workday, the participants responded to short surveys, also known as experience sampling questions, about their stress levels in the past 30 minutes. In addition, at the end of the workday, they reported on the intensity of 10 predefined workday stressors. Furthermore, we gathered variety of passively sensed data about our users' work routine to their work machine. The data was collected by a custom logging software. We investigated whether any of the features calculated from the passively sensed data were significantly correlated with the daily stressors. On this slide, I will only reflect on the overly packed day stressor. Overly packed day was positively correlated with the average time spent on different applications, the total number of busy slots based on the calendar invites, the total number of open applications, the total number of meetings, and the median value of facial action unit 12. This can be indicative of high number of meetings and more smiling gestures associated with social interactions, respectively. To model the performance of our stress detection model, we computed the F1 score of our machine learning model. We used the random forest model for modeling the stress levels. We found that our stress detection model has poor generalization for unseen participants. However, by adding more personalized data from each participant, our model performed better. In this plot, the y-axis represents the F1 score, which is a robust measure for evaluating model performance. The x-axis represents how much data the model could learn from each user since the beginning of the study. Hence, we found that personalization was significant for in-the-moment stress prediction.
Hi, everyone. My name is Esther Howe, and I'm going to be presenting on the intervention study results that Mehrab mentioned earlier.
Esther, I think you may be in the wrong room, or just in the midst of
no, Esther is in the
sorry,
I'm doing this over. I'm so sorry.
It's okay.
Sorry.
So Mehrab is just going to keep sharing his screens, but I'm going to be the one talking. Just
got it. So sorry.
Yeah. So as Mehrab mentioned earlier, we then conducted a study to assess the impact of brief digital stress reduction interventions. Our study design was very similar to the stress sensing study design that Mehrab just outlined. Participants completed daily and weekly surveys to assess their stress levels over the course of 4 weeks, but in this study, they also completed digital stress reduction interventions throughout. Participants were 86 Microsoft employees. They were all people who had opted in, consented, and could leave the study at any time. And it just so happened that the sample we collected reported subclinical levels of stress at baseline, as measured by the stress scale on the DAS-21, the Depression, Anxiety, and Stress Scale. Participants had access to a library of over 50 brief digital micro interventions, and these interventions fit into 3 types of interventions with 3 categories: low effort interventions, medium effort interventions, and high effort interventions. Low effort interventions were things like positive mood inductions, distractions from work. Medium effort interventions were mindfulness exercises or grounding exercises, and high effort interventions were more problem-solving focused, things like helping participants through a pros and cons list, things that required people to be more cognitively engaged. And so what we found with these 3 types of interventions were that medium effort interventions, the mindfulness-based interventions, were the least effective. We found that low and high effort interventions were equally effective. And we found that low effort interventions received the highest ratings. So across multiple metrics, these low effort interventions seem to win out. They're both one of the 2 most effective types and the highest rated. We also tested 2 timing conditions, a just-in-time and a pre-scheduled condition. So we found that people in the just-in-time condition received interventions when their stress scores were above average, according to the stress sensing metric. And people in the pre-scheduled condition browsed the intervention catalog beforehand at each week and scheduled interventions for themselves throughout the coming week. We found that users preferred the just-in-time interventions. In other words, when they were given an intervention when the system sensed that they were having above average stress, but that both conditions, both the just-in-time and the pre-scheduled, were equally effective at reducing momentary stress. So what are the implications of these findings? Overall, our study showed feasibility of integrating stress reduction interventions into a specific context, in this case, the workplace. And future systems should offer opportunities for self-reflection and higher levels of personalization, or in other words, future systems, we believe, should collaborate more with users to determine content and system features. Similar systems could be developed to help clinical populations function more fully in the workplace. And please see our paper if you have any more questions or would like to hear more about this research. Thank you all so much.
Wonderful, thank you. And Esther, I apologize that I misunderstood what was happening during the handoff there. So let me open it up for questions.
Esther, for the intervention study, I had a quick question. For the just-in-time intervention, is that based on the assessment schedule? Like, I mean, I imagine if your day is overcrowded, as Merab made, you couldn't actually have a just-in-time stress intervention because you're in meetings and you have to do things, right? So how was that scheduled for the just-in-time portion of that?
Absolutely, that's a great question. So the just-in-time intervention was triggered based on this stress score that took into account passive sensing data as well as the self-report data. And the passive data streams included things like calendar, like that Merab was mentioning. So we wouldn't trigger an intervention while somebody was in a meeting. We would take that into account and trigger an intervention when they had free time. You are correct that there were likely instances in which people were simply too busy to even do an intervention on that day. And in that case, you know, in future iterations of an intervention system like that, it would be excellent to try to plan ahead for days like that and encourage folks to do stress reduction, you know, the night before or early in the morning.
Great question, thank you. Wonderful. And please follow up in chat with folks with additional questions. I want to make sure we have a chance to hear from everyone though. So I'm going to move forward and we'll hear about investigating heterogeneous treatment effects of a standalone digital mental health intervention versus digital mental health intervention as adjunctive care, a dismantling quasi-experimental intent to treat study. And it looks like Benjamin's able to share screen. Wonderful.
Hi, everybody. Are you able to see our title slide here? Okay.
Absolutely.
Fantastic. Well, it's wonderful to be presenting with all of you. My name is Benjamin Nelson. I'm a clinical research scientist at Vaile Life Sciences, but the work that I'm going to be presenting on today is currently a preprint that's under review, and it's based on past work from my previous employer when I worked at Meru Health. At the time of this work, I was an employee at Meru Health and received a salary from them, but they had no role in the conceptualization, design, analysis, interpretation, writing of the manuscript, or decision to publish these results. And these findings don't represent anything that has to do with my current employer. So let's jump right in. Okay, so over the past decade, there's been a growing literature on smartphone-based digital mental health interventions for depressive and anxiety symptoms. These interventions have been described as a purported solution to meet the growing mental health demand needs and lack of providers, while also cutting healthcare costs and expanding access to care to underserved populations. Unfortunately, these interventions have often not accounted for whether or not patients are using digital mental health interventions as a standalone treatment, so solely using that digital mental health treatment, or using it in combination concurrently with another treatment modality, such as gold standard in-person therapy, psychotropic medication use, or a combination of these interventions. And this has large implications on the scalability of treatment for different patient populations, as well as the healthcare cost implications if these underlying assumptions lack evidence. In other words, if we're saying that digital mental health interventions are actually going to expand access to care and cut costs, but patients are still using in-person providers, that may kind of undercut that assumption. When data on concurrent treatment types are collected, these variables are typically used to adjust for efficacy and effectiveness analyses as a covariate rather than stratifying patients by treatment type. And the omission of this combination of treatment types, when combined with the lack of large-scale RCTs in this field, has the potential to inflate treatment effects in observational studies. Leveraging the existence of natural experiment designs may yield informative results about the comparative effectiveness of these treatments that emulate RCTs and provide a robust base rates for further investigation of RCTs. And this brings us to our current study. So this quasi-experimental intent to treat study had 354 patients, and it was pre-registered on Open Science Framework. The link is right there for all of your reference if you'd like to delve into the paper a little bit further. And the goal of this paper was really to compare the effectiveness of the Marrow Health Program, a therapist-supported, evidence-informed digital mental health program on a smartphone app, as a standalone treatment as compared to the Marrow Health Program as an adjunctive form of care. To examine this question, we broke the study down into a 2-arm design and a 4-arm design. In terms of the 2-arm design, we looked at the Marrow Health Program as a standalone treatment, or the Marrow Health Program as an adjunct to any other treatment modality, including things like psychotropic medication use, in-person therapy, or some sort of combination of those. We then broke these results out even further in a 4-armed approach, where we again looked at the Marrow Health Program as a standalone treatment, the Marrow Health Program combined with in-person therapy, the Marrow Health Program combined with psychotropic medication use, or a combination of all of the above. So to start out, these are some descriptives on our results. So we can see that over half of the patient populations that were presenting for a digital mental health intervention were not using the Marrow Health Program as their sole means of intervention for any mental health difficulties that they were experiencing. The vast majority of them were actually also in in-person care using psychotropic medication use, or about 1/5 were using in-person therapy, psychotropic medication use, and were in our digital mental health intervention. In terms of PHQ-9 symptom trajectories across time, here you can see the treatment week at the bottom, which it's a 12-week treatment protocol. And on the y-axis, you can see the PHQ-9 scores. And then here we see individual patient scores kind of opaque in the background and more bolded lines that's group means. And we can see the decrease in symptoms across time for each of the 4 treatment categories. What we found was treatment week was significantly associated with lower PHQ-9 and GAD-7 scores, and that patients that were in the Marrow Health Program as an adjunct to any other form of treatment had significantly higher PHQ-9 and GAD-7 scores across treatment. When we ran follow-up analyses in the 4-arm approach, we saw that this was largely driven by the purple line, which was patients that were in the Marrow Health Program in-person therapy and taking psychotropic medications. And here we can see the same results for GAD-7 symptoms across time. All right. In terms of exploratory results, we looked at presenting problems for each of these 4 groups of patient populations, and we found that patients that had higher baseline depressive and anxiety symptoms, so patients that were presenting with greater symptom severity, were more likely to self-select into multiple forms of treatment. And this effect was also driven by patients that used the Marrow Health Program as an adjunctive treatment to both in-person therapy and psychotropic medication use. In addition, patients that used the Marrow Health Program in combination with any other treatment had higher rates of major depressive episodes in their past, higher rates of psychiatric hospitalization, and greater attempted death by suicide when they came into our program at baseline. Some limitations of the study: it was not an RCT. It was a predominantly white sample, almost 80%, which doesn't meet the assumption that digital mental health interventions will increase access to care. It did not collect type of in-person treatment, so whether it was an evidence-based in-person treatment like cognitive behavioral therapy or mindfulness-based stress reduction or any form of in-person care. And these results might not generalize to other therapist-supported digital mental health interventions that have phone calls or video chats, as the Marrow Health Program therapist-supported intervention primarily relied on text messages with patients. In conclusion, more than 50% of patients that present to digital mental health interventions are using it as an adjunct care to gold standard treatments. Patients with higher depressive and anxiety symptoms tend to self-select into using digital mental health interventions as an adjunct to more traditional care types rather than a standalone intervention. And these patients have more severe clinical characteristics at baseline, including higher rates of major depressive episodes, psychiatric hospitalization, and attempted death by suicide. The use of digital mental health interventions, however, is associated with similar treatment gains across treatment, whether it is used as a standalone or augmented treatment. In other words, the slope of symptom reduction is the same for all groups, although the level of symptoms across treatment is different. And with that, thank you, everybody. I'm happy to open this up to questions at this point.
Thank you so much. Let me open it up. We probably have time for one question. I wonder if you could talk a little bit about, you talked about the fact that the sample was relatively homogeneous in terms of racial and ethnic identity. And I'm curious if you think that some of your take homes about fit and ways this was being used and all of those kinds of things would differ if you had had a more diverse sample.
Yeah, I think that's a great question. And those are obviously some questions that, we would need an evidence base to come to a firm conclusion on. But I would think that there would potentially be differences. I think at this point in time, the adoption of these sorts of interventions have tended to skew predominantly white and in more tech heavy areas rather than in more diverse and or rural areas. I think some of that has to do with advertising of treatments and that we're just kind of in the infancy of these interventions at this point in time. But regardless, I think any digital mental health intervention treatment that's created or is being created at this point in time, kind of hearkening back to some of the prior talks that we've heard of, I think they need to be established and built with community representation and inclusion from the ground up so that we can ensure that we're generalizable to each patient population that we're trying to serve.
No, absolutely. Wonderful. Thank you so much. And we're going to see now, Jaan's been able to rejoin and see whether that will work now to share screen and present. And that talk's going to be Algorithmic Fairness in Digital Mental Health.
Fantastic. Can everyone hear me okay? I'm just starting the iPad screen sharing.
We can definitely hear you. And it looks like it's
Okay.
just coming in. We're seeing your desktop right now.
Fantastic. And you can see when I write something. Let me see.
It's buffering, but it's it looks like it's coming on there. Yes, you're good.
I just wrote the word test. Okay, great.
We're with you.
Nicole, do you mind? We're gonna try a little demo for y'all about mental health and digital healthcare delivery. So let's see if this complicated tech setup is working. I have two coworkers with me. We all work at the same nonprofit. I'm Dr. Jaan Altosaar. And so for the first demo of how to deliver mental health care, we'll have Emily show us what the Apple Watch looks like for heart rate variability biofeedback. And so what heart rate variability biofeedback does, it gives you a sense of your autonomous nervous system activation and the root mean square standard deviation between consecutive heartbeats, say in an EKG or a pulse ox signal, that tell you how variable your heart rate goes up or down with each consecutive breath. And this is a very popular device, especially among tech bros like me. I used to work at Google, and then every podcast that's like Andrew Huberman or Tim Ferriss or Peter Attia will try to sell one of these devices and then try to market it as like a mindfulness, stress reduction, mental health tool. And so, Emily, do you want to give us a demo? Let's see if we can show the...
Hello.
Yeah.
So, I don't know how helpful this will...
Loud. Yeah, say it loud.
Yeah, I don't know how helpful this will be. Like, it's kind of like in French. But basically, it like monitors your heart rate and stuff, but there's also like the possibility of kind of doing some mindful like breathing. And so it like gives you a program where you like breathe in and out depending on like it times your breathing basically to try to like calm you down, and it also measures your heart rate as you're doing it. So
awesome. Thank you, Emily. And so what we just saw was a demo of like a real-time photoplethysmography, which I can walk through how that works. And that is a commercial tool because Apple is like a $3 trillion company, second most valuable company in the world after Saudi Aramco. And now we can think about how photoplethysmography works and whether it's equitable, because this is about algorithmic fairness in mental health and healthcare more broadly, because pulse oximetry or arterial oxygenation is one of the most common vital signs in the world in every primary care visit. And it's also a very scalable mental health tool because all you literally need is a pulse ox, which is a couple bucks on Alibaba in bulk. You can buy pulse oximetry monitors and help reduce levels of PTSD, or help manage, say, bipolar symptomology, or say have other such interventions that don't necessarily need the same amount of clinician time as CBT or DBT or ACT do, because it's just the patient. Like as you saw Emily, I don't think she's a patient, or at least I can't reveal that information because it's PHI. But if she were a patient, then she doesn't need a clinician, she just needs her Apple Watch, like this commercial product, to breathe, and then that might help manage her symptoms. And so that's kind of the background of like current commercially available tools. Like one is, say, like PPG. Let me just see if I could make this larger. So PPG for scalable mental health. So first we saw the Apple Watch. There's also commodity ones off Alibaba. How much does the Apple Watch cost? It's like 400 bucks or something. The Alibaba pulse oxes cost like $3. And then 3, I'll show you now a demo that you can do yourself. That'll be hands. This is if you have hands. If you don't have hands, it'll be expensive. But if you have hands, then you can actually do this exercise yourself with your hands and feel your heart rate variability. So it works like, just feel your pulse regularly. Feel free to turn your video off if it's uncomfortable, but see if you can feel your pulse. Sometimes closing your eyes helps. And then as you tune into feeling your pulse, then let me just angle the camera down a little bit. Then a little bit of extra biofeedback is if you have 2 hands, if you're lucky enough to have 2 hands, then you can feel your diaphragm like push out the tendon in your muscle. So your shoulders shouldn't move during this exercise. That's all about the diaphragm. And as you breathe in, your diaphragm contracts, a tendon pushes out. Hopefully you can see my stomach moving. And so those 2 things are all you need to experience heart rate variability in real time with a cost of $0. I think it disappeared, but I'll just rewrite it. I lost my Apple Pen. Oh no. There we go. $0. And so if you are able to feel your pulse, the next step is to do that diaphragmatic breathing and try to maintain a cadence of like 4 seconds inhale, 6 seconds exhale, or 6 seconds inhale, 6 seconds exhale. And then pay attention to when your heart rate increases or decreases, like when it accelerates or decelerates. And it's a very, very simple exercise, and it's literally what this $400 Apple Watch does. It's what the $400 like heart math product does that's marketed on podcasts. And it's very interesting to understand that it is just simple physiology, because the way the diaphragmatic breathing regulates your heart rate variability is by pushing your organs out of the way of your heart. So normally your heart is a little bit compressed because your organs are all up in there, like around your heart. And then your diaphragm kind of looks like a balloon. And as your diaphragm constricts, as you breathe in, your stomach moves out, your diaphragm is actually going down and moving your organs out of the way. So your heart expands a tiny little bit, and that tiny little bit of extra heart space, like quite literally heart space, is enough to increase the conduction of the electrical signal by a few milliseconds. And that starts the like I think it's the sinoatrial node. Like in your heart you have a timekeeper, the sinoatrial node, and that is where the action potential starts. So this is going to be a horrible diagram of the chambers of the heart, but somewhere here there's a sinoatrial node, and then this connects directly to the autonomous nervous system.
Letting you know that you're at the 7-minute mark at this point, so just letting you know.
Sure, thank you. And so it's almost done. So the way it works is that by a few milliseconds of conduction around the heart, because your heart has more space when your stomach expands, that gives your autonomous nervous system outside of your conscious control signal to decelerate your heart rate. So when you go like this and you breathe in 4 seconds in, 6 seconds out, you can actually feel your pulse increase or decrease. Pure biomechanics. And so when I was thinking about scalable mental health delivery models, then I think of all the corporate incentives that a $3 trillion company has. That one, there's like so much research on how photoplethysmography does not work for Black people, does not work for Latino people, because melanin blocks the LED signal. It's just literally like light absorption decreases transdermally, so it's unreliable. But we already have $0 tools to do this, so why aren't we using them? So thanks so much. I'm happy to take any questions, and shoot me an email anytime. I'll put my email in the chat.
Wonderful, thank you. And great, if you want to put your email in chat, that's great. And I'll stop the sharing just to make it easier. Any questions for Jaan? We're coming close to the end of our time. I would love, as we're wrapping up here, I mentioned to, I think, one of our earlier presenters to share their, Catherine, to share their contact info for those who are interested in joining the Equity Network. And as we sort of come to the end of this presentation time, I want to thank everybody for the fabulous talks that people did, and ask people to share their contact info in chat if they're willing to, and if they are open to people following up on them and they haven't already shared their information. And what we will do is, you're welcome, we've got a couple of minutes, so people are welcome to ask questions of presenters if they haven't had a chance to ask, and then we'll move back to the wrap-up session in just a minute. So let me open it up and see if there are any last questions or comments for those who either just presented or presented earlier today. Merab, I'll take us back to one of the pieces that you talked about. I'm curious about the training data that was needed for personalization for the models that you were talking about.
Yep, sure. I believe the question was for me.
I was asking how much training data was needed in order for the models to be effective in terms of the personalization and stuff.
So we gathered data for a month for the stress sensing and both the intervention studies, and we found out like approximately at the third week we gained about, like, I believe 70% F1 score, and the benchmark performance that we got was if we used up like all of the data. And essentially, like, each day the participants reported approximately like 5, I believe, stress questionnaires, which were like the last 30 minutes. So on an average, I would say like there was heavy amount of data that was necessary for people to reflect on their stress levels. So that was one thing that we wanted to look at, partly because of, like, we talk about the stress in workplace a lot, but at the same time, we rely on, or like expect that a cold start approach might work. But in this case, we found that it actually didn't work, which kind of reestablished or reiterated some of the findings that we were already expecting in the stress literature, but now in a more constant remote work setting.
Great, thank you very much. I appreciate that. Any other questions? All right, well, we're at 2:49, so exactly on time. So I'll encourage people to move back and join the Society for Digital Mental Health Day 2 wrap up. And thank you so much, everybody, for your participation.